All right. Well, good afternoon. My name is Danae Hebert. I'm the Executive Director of the Louisiana Rural Health Association. Thank you so much for joining us for this Rural Infection Prevention and Control Training Program webinar. LRHA is happy to present this program and webinar series with sponsorship by Well Ahead Louisiana and in partnership with Southern Evals. Today's session is part 2 of the Advanced Hospital Infection Prevention and Control Training. Just a couple of housekeeping items before we begin. This webinar is being recorded. It will be available along with a copy of the slides on our website at lrha.org. I will put the direct link to the relevant page in the chat box. This is actually our last webinar of the webinar series. So be sure to go back to that page and review any webinars that you may have missed or get a refresher on any information. Your line should have been muted automatically when you join the session. Please remain on mute until you're asked to speak or until there's a Q&A session to prevent background noise. After the webinar, we'll send you a link to a brief survey to complete. I'll pop it in the chat and I'll send it out via email. We do ask that you please complete that survey. It's required for our grant evaluation piece, and it also helps us to continue to improve our future events. So with that, I will welcome Taylor Katana, who's the founder and CEO of Southern Evals. Taylor is a board-certified infection preventionist and has previous experience as a frontline nurse specializing in critical care in both medical and surgical intensive care settings. So thank you so much, Taylor, for being here, and I'll hand it off to you.
All right, thank you so much, Danae, and welcome everyone to the last webinar of the series, the Louisiana Rural Infection Control Training Program. Today, we are covering some pretty in-depth topics. Being that it is the second advanced, we're going into depth on some specific items CMS Joint Commission, those regulators are looking for. So without a doubt, let's get started. Okay, shout outs. Good morning, shout outs. Where are you from? How long have you been in the infection control role? And are you signed up? So let's look at Miss Amanda Carroll. Let's see, Miss Amanda, we're gonna ask you to unmute. There we go. Should have got a request. All right. Let's move. Well, Miss Amanda isn't there. Maybe she's on the phone. What about Miss Jen?
Hello, Taylor.
Hey, Miss Jen, how are you?
I'm good. How are you?
Oh, doing just fine. Okay, tell us where you're from, how long you've been in the role, and are you signed up for the program for the on-site visits?
We're calling in from Ville Platte, Louisiana.
Okay.
I've been in infection prevention for 10 years.
Awesome.
And we are not signed up.
Okay, well, definitely after the webinar, make sure you go on there and sign up, because if this is one of the first ones you caught, we're going to be able to come on site to do a small assessment, offer any resources that you may need, and then also Danae and the LRHA have a pile of resources. So PPE, some technology, all that we can drop off. So make sure you sign up.
Awesome, will do.
All right, perfect. Well, good. Well, let's get started. So again, who is Southern Evals? We are a regulatory compliance healthcare consulting firm. Our mission is to help hardworking healthcare providers increase revenue and maximize patient safety. Our values are honesty, transparency, consistency, hard work, and compassion. And our vision is to provide safer care for 1 billion, big old number, 1 billion patients by helping 10,000 healthcare providers succeed. And how we do that is working day to day with providers in as small as clinics to as large as hospitals, understand what regulatory requirements they have to follow, and then making sense of those to translate into safer care. All right, so Hospital Advance 2. So this is going to be a review of the best practices when handling CAUTIs, CLABSIs, surgical site infections, and other adverse conditions in the hospital. So if you are new to this, you don't quite know what those acronyms are, we're going to walk through those and make sure that you understand the intricacies, what's required, and what surveyors are looking for with those things. Okay, the 3 Ps. Paperwork. Danae, are these pictures showing up, or is that just on my screen?
They are not. I see gray boxes.
Okay, let me see if I can go ahead and fix that real quick. Give me 1 second, folks. My apologies. I don't know what happened there. Let's see. All right. There we go. Let's see if this will fix it right here. All right, I think we're good to go. Let's get back into it. Sorry, y'all. You know how technology is nowadays. Danae and I were talking about Zoom and how awesome it is, but boy, it is not like being in person with somebody. So, okay. Now getting back to the 3 Ps. Danae, can you see my pictures now?
We can't see the slides. I think you need to share again.
Okay, gotcha. Give me 1 sec. Let's see. And right. Share screen. Okay, how about now?
Yep, perfect.
Okay, excellent. Okay, so in the past, we talked about the paperwork. We talked about your acknowledgement statement, your plan, your risk assessment, your evaluation, all those base elements that you needed. In the middle, we talked about policy and procedures, all of the things that you do on a day-to-day basis, having the procedure behind those and making sure you're doing those. And we talked about practice, the rounding in your facility, the hand hygiene monitoring, the tracking and trending of data. So we talked about all of those different things. And remember, you can always go back to those other webinars and get reminded of what you need to do with those. But today, we're going to focus on the in-depth situations and topics of these hospital-acquired infections. And remember, you can make a difference. You can make a difference. It's up to you as a healthcare leader to make a positive change that will have a positive effect on your community, especially if you are in rural areas. I cannot stress this enough. You are the go-to for everybody. Folks don't know healthcare like we do, and it's scary whenever they come into the hospital. Know that you make a difference whenever they come in, and keep doing the good work. All right, types of infections and definitions. So, healthcare, we deploy a whole lot of different things. Healthcare has changed a ton. New technologies have evolved, all to treat patients, to recover, and to heal quicker. So, problem with that is anytime we are entering sterile space, doing different procedures, and we have something in the body that doesn't belong in the body, there are infections that can happen. So, we're going to talk about infections that are associated with those medical procedures, catheters, those different things, and how we can work to prevent those. Okay, this was one of the things of why I got into infection control. Being a board certified preventionist, maybe it's some folks' dreams, but whenever I was a nurse, I didn't even know what it was. But it wasn't until I started getting into practice and someone walked me through what it was, and I've kept this with me throughout my whole career, is the goal of what we do in infection control and as a clinician in the hospital, even housekeeping, even leadership administration, is we do not want to make patients sicker than they already are. Okay. They don't want to make patients sicker than they already are. So these folks are coming in, they already have something going on, or they don't feel well. And the last thing we want to do in the hospital is put them in further jeopardy. Or we don't want to do something that's working to make them feel better or function better, and then they're coming back to us even sicker than they were. Okay, safety is our duty, and we have to remember that day to day. I know we are in this environment, so many hours a week, and we see it over and over in tons of patients, but safety is our duty, and we have to have that focus and compassion for every patient that we treat. Okay, types of HAIs, hospital-acquired infections that we're going to cover. We're going to talk about CLABSI, which is a central line associated bloodstream infection, which is when we're dealing with central lines that we administer medications through. CAUTI, catheter-associated urinary tract infections. CAUTIs being, or urinary tract infections being the biggest hospital-acquired infection in the nation. And catheter use, we're going to talk about some of the stigmas and some of the things that you can do to try to prevent those. And then also surgical site infections, SSIs, any kind of procedure that you may do, even if you just do not true surgery, but like procedures like endoscopy, pain management, those kind of things. Still, you could want to focus on some of these things to make sure that you are not inadvertently causing infection. So know the class to pass, know exactly what you're dealing with. That way you can take steps to make sure that you're providing safe care. Okay, First one we are going to talk about is central line associated bloodstream infections, okay? So our regulatory guidelines, remember, this is kind of what we function on a day-to-day basis in our firm is we are checklist folks. So we want to make sure we are checking the box to make sure we're doing the things that are required. And inadvertently, these things are put in place to make sure that we keep patients safer. So Joint Commission NPSG, National Patient Safety Goals, what that stands for, on central line associated bloodstream infections are the following. We implement evidence-based practices as such as education of employees and licensed independent practitioners who are involved in central lines at hire and periodically thereafter when this is added to a staff's job. So education is a huge component of what is required here. There's a lot of different things going on with central lines, and you want to make sure that your staff understand every single step. And we're going to go through those in a sec. Prior to insertion, educate patients and families about prevention of a CLABSI. Look, this is something new, a central line. It's something that's going to be going into their body, that they're going to be getting medications through. This is unfamiliar. This does not happen unless we're in the hospital. So make sure they understand every piece. And if it's something that they're going to have for an extended period of time, make sure they understand the risks of having it and how to prevent those things. Knowledge is power when it comes to this, not only for your staff, but for that patient as well. You want to implement policy and procedures aimed at reducing risks. These must meet regulatory requirements and be aligned with evidence-based standards. Again, policy and procedures are there so that your staff can go back and reference what you want to do in your facility, or if there's ever any confusion, they can always reference those. Also, they are educated on those, so making your policies clear is what you expect, and based off the evidence-based standards is very important. Conduct periodic risk assessments for CLABSI rates, monitor compliance with evidence-based practice, and evaluate the efforts. Time frame for an assessment is set by the hospital. Okay, so whenever you do your risk assessment, like we were talking about, make sure that you're looking at CLABSIs. I'll just say this, for all hospital-acquired infections, you want to make sure that you're paying attention and looking at that as a risk in your facility. And if it is something that you're seeing a lot of, you want to make sure that's a priority and you are identifying ways that you can get better and prevent those. Then provide rate data and prevention outcomes. Look, not only do you want to do this in your department, but share that with leaders. And we're going to talk about leadership, how important it is to have buy-in when it comes to preventing HAIs. But this is something great when you're tracking that data, sharing it with your leaders, your practitioners, your nursing staff, your clinicians, and as well, if you've got a contract company that does central lines for you, then you want to make sure that you're keeping them on par and understand where your numbers are. So time and timeliness, and you'll hear me say this about central lines, about catheters, about anything, is you want to make sure that the intervention that we do, and this is a regulatory deal that they're going to be looking for, any intervention that we do, we try to remove that or take that out of the picture as soon as possible, because the longer that lasts in the body or lasts with that patient, the higher the risk of them to acquire an infection, okay? Okay, moving on, use a catheter checklist and a standardized protocol. Use a standardized supply cart or kit that contains necessary components for insertion. What do you hear here? Standardized. Having a standardized process, kind of like, a lot of folks will see it in an airline. They go through strict step-by-step process. It has to happen every time. It's checked. And if something is missing, we go back to the beginning and we make sure that we have it right. The same thing goes with central lines or any catheters. We want to make sure that we have a process, step-by-step process, and that as preventionists, if we're not the ones performing the standard, whenever we go and look at those, that checklist is being followed. We're educating on that checklist, and it is a standardized process so that one person that does this compared to the next, compared to the next, compared to the next, understands exactly what needs to be done, and it's all on the same checklist. Next thing is hand hygiene. It's the biggest thing for many of these you're going to hear. Shoot, it was throughout the whole presentation. Hand hygiene is so important, especially prior to insertion. And anytime you're doing any manipulation or dressing changes, hand hygiene is key. You want to use a maximum sterile barrier or use those sterile barrier precautions during insertion. Don't skimp on those. Make sure that everything is covered. Again, this is going to be part of your standardized protocol on how to set those up. Use alcohol or chlorhexidine for skin prep during your central line insertions, unless it's contraindicated. Again, there will be allergies, but Again, so we washed our hands. Now those are clean. Now we need to make sure the site is clean. We want to remove anything that once we go into that sterile site or into that body, that we are not dragging anything, pulling anything in there with this catheter. So cleaning that area, disinfecting that area. And then if you do have allergies, making sure that that patient, we use something else that they're not allergic to that gets the same job accomplished. Again, you'll see use a standardized protocol to disinfect the catheter hubs and injection ports before accessing them. And then evaluate your central venous catheters routinely and remove those that are not essential. So we talked about those 3 points: washing our hands, cleaning the site. Now, once we insert that, now you've got hubs that you're going to be pushing fluids in, pushing medicines through. We want to make sure that anything that can enter that, kind of like a wall, we want to make sure that we clean before anything goes in. So those hubs, you want to make sure that you scrub those hubs, or you use your green caps or whatever color caps you have to make sure that those ports are clean before you enter those. Also, remember, one syringe, one patient. We don't use multiple syringes. We don't use multiple things. We use one for that, for what we're doing, and then we get rid of that, okay? And then evaluation. You want to make sure, like I said, time and timeliness is so important. If this is not needed, do not use it for convenience. Make sure that your nurses are assessing these. Make sure that if you're in a smaller hospital where you can go around and verify these, look at these on a day-to-day basis, even a weekly basis, that you do that. Because there may be things that that you can see that can prevent that infection. Okay, so when we talk about these, a CLABSI, let me define it for you. This is when bacteria or viruses enter the bloodstream through that central line, okay? So like we were saying, you've got that line that's going inside that body, inside that sterile area, and now we are introducing pathogens, bacteria, or viruses into that. How can that happen? One of a couple, many things could happen, but all of those portals for entry, bacteria or viruses can enter at any of those points. Sterile process to insert central line is so extremely important. We have to make sure that our process is being followed, that standardized process walks through every step of the process, from prep to putting our sterile barrier on there, to our washing our hands, to what we're wearing, our PPE. It's all needing to be in our steps. We need to keep it as sterile as possible. Healthcare providers must care for the line and change dressings. We're looking for different things in those lines, like integrity. We're looking for if those, if that site is having any, any swelling. We're looking for that site to have any redness. We're looking to see if that dressing is loose or it's dirty, or it's got, different things on it, or it's not intact. All of those things, it's so important for a healthcare provider. And the only way your healthcare provider is going to understand what they need to look for and what they need to do is educating them on the specifics of this. Okay, things to look for: fever, red skin around the site, soreness around the central line. Okay, all of those things. When we're going to assess that, if we're noticing a spike in temperature, or we see that skin is red around that site, or that whenever we manipulate that to check it, it's extremely sore, more sore than it usually is. Those are going to be signs that we need to start looking to see if we're starting to get an infection with that. And then time that it is present is a huge factor. Again, I'm repeating myself, but these things are so key. The sooner we can take this out, the less risk we have, okay? The longer that these lines, that these catheters stay in, the longer we have a chance for bacteria or viruses to enter, okay? The body, usually adjusts well, but it doesn't like anything foreign inside of it, okay? So we want to make sure that we're good stewards of that and we are not introducing anything. So best practices: hand hygiene, aseptic technique. I cannot stress this enough. Hand hygiene is one of the most important things that we see, and especially with central line insertions, these are so important. Aseptic technique, again, on that checklist, making sure that everything is down. We're cleaning that site. We're making sure we have a brand new set. It wasn't open or anything. We're making sure that, whenever we use those hubs, we're cleaning those. All that aseptic technique is so important to prevent that. Maximal sterile barrier precautions, make sure that everything is covered. There's no way that anything can come contaminate the field. And you want to make sure that that focus is paid attention to that line whenever you're doing that central line insertion or that central line care. We don't need to be doing 5 million things, because at that point, we may be compromising that barrier. Standardization, again, a checklist is so important here. There are so many steps, especially when you get intricate like this, so many steps from beginning to end to care that you want to make sure that you've got either flow sheets that you create or go to the CDC. They've got some great resources as for you to take and to use for your insertions or for your different deals. Your checklist, some of those things in your checklist are a process to choose a site. Insertion under ultrasound to make to where we're not spending a long time trying to find this thing. Catheter site dressing change regimens. How often are we doing that? Securement devices so that we don't have catheters that are moving or loose. And also, we always recommend use a process bundle. So whenever we talk about a process bundle, it takes all things into account: the documentation, the process, and then the routine care, follow-up, all the way to the removal. We've got a process bundle that covers all those different things. That way we know from a preventionist standpoint, we can go back, review that bundle to make sure all of those items have been done. And if any of those steps, we start to see that infection, we can go back and identify what we may be, what may need some tweaking, what may need some work to prevent that in the future. Some more best practices is proper maintenance. Again, whenever that central line is in, how do we make sure that while it is being used, it has the proper integrity, it's being secured properly, all those different things. Disinfection of catheter hubs, connections, injection ports, changing dressings over the site. This is best practice that we've seen every 2 days for your gauze dressings or every 7 days for your semi-permeable dressings. So those ones that stick on there, that you can see, make sure that you change those 7 days. And there's a whole lot of different vendors. This is what we've seen on a regular basis. That dressing, again, we want to make sure that we're not just sticking the dressing on and leaving it. We change that when it becomes loose, damp, or visibly soiled, and we remove or replace the central line at the appropriate time safely. We get rid of it as soon as we don't need it. We don't keep it there for convenience. Look at it daily. I think, many of the smaller hospitals that we work with, their average daily census allows them to, if they have time, to go just put an eye on that, go check in on the patients, see how they're doing, and talk to the nurses about that. As a preventionist, that's going to be, since safety is our duty, we need to make sure that that we're checking in on those, and we're not caught off guard if something were to happen. We want to be on the ball looking at those, so if something does happen, we can quickly adjust and treat. So I'll just say one more thing on CLABSIs. Many times in hospitals, we see contract companies that come in that do these. I will say this, and the Joint Commission will say this, and CMS will say this: do not depend on your contract companies to do everything properly. Again, do not absolutely trust that your contract companies are going to do things properly. Case in point, I'm actually in Chicago right now. We had a Joint Commission survey. We had a vendor cleaning ice machines. And when we looked at the ice machine, it had been checked off. We had documentation from the vendor. They said, oh yeah, we did everything. We got some just junk growing up in this thing. So valuable lesson for me, valuable lesson for the facility: do not trust your vendor. So when it comes to central line insertion, to whatever kind of vendor you may have, it is not a bad thing to go back and audit those folks. If they don't have a checklist, make sure to work with them to maybe implement one. Because if you're seeing central line infections or CLABSIs that are coming through your facility, you want to make sure that you are identifying where they're happening. And with that contract company, they're paid just to make sure that they get the job done. And they're paid for how many they do. So whenever you're putting time, money in the situation, some things go out the window. So you need to be a steward of that, making sure that they're doing the things properly, and that if you want them to follow guidelines, that they're following those guidelines. Okay, we're closing the chapter on central line now, and we're going to surgical site infection. So Danae, I just want to pop this up because a lot of the smaller facilities we work with don't have surgery, but how many of you guys have surgery in your facility? Either surgery or endoscopy or pain management or anything where you're entering a sterile site or mucous membranes or anything like that. Okay. So we got half and half right now. So that's out of 4. Yep. So we got a couple yeses and a couple nos. So, this is going to be a section where we strictly talk about surgical site infections. For those of you that have surgery, you understand that there's a lot that goes into it. And especially as a preventionist, many times we have a manager over that surgery suite or that procedure suite. And we really depend heavily on them to do a lot of the heavy lifting there. As a preventionist, you still need to be very conscious of what's going on in surgery or your procedure areas. And you need to make sure that you're talking to those folks, communicating with those folks, to where if you're seeing those surgical site infections coming back within 30 days, you start doing a little bit of digging and you look. So the first thing I'm going to show you is that CMS has these guidelines on your checklist that you can access. But you see this, they've got a load of things when it comes to surgical procedures. One of the first things is we perform surgical scrub before donning sterile gloves, all the way down. A fresh, clean surgical cap is worn, sterile drapes are used. So when it comes to surgery, we're not going to dive into every little thing that they require when you're doing surgery. We're going to talk about the surgical site infections and what you need to pay attention to in your facility, okay? Again, surgery, what your surveyors are going to do, they're going to want to come in, they're going to want to watch a case, they're going to want to see if everything is being done properly. We talked about a lot of those things in the last one. We talked about reprocessing, but this is going to be a site where they'll also ask you about your surgical site infections and your rates. So you need to be able to speak to that. Okay, your guidelines, Joint Commission, implement evidence-based practices for preventing surgical site infections. So you see, again, at the top of these lists, educate your staff involved with surgical procedures about SSIs, the importance of prevention on hire and annually whenever they have involvement. Education. Also educate the patients and families who are undergoing the procedures. See, these things are unknown, especially for a patient, whenever we're reviewing things and it's like, yeah, Miss so-and-so just had a hip replacement and she went swimming in Toledo Bend 2 days after. Well, that's not a good practice. Of course, we're going to get infection. Now she's coming back in, it's blowed out, and then she's got drainage coming out. Well, maybe we didn't educate that patient the best to say that, hey, look, you don't need to do that. You need to hold off from your normal activities. Education is so key because we can never assume that they know what not to do or what to do. It's up to us to make sure that they understand. Implement policy and procedures aimed at reducing the risk. So policy and procedures line out what we do in surgery. They line out how we dress. They line out what we drape with. They line out cleaning, washing hands, sterile prep, all of those things. Also, we need to have guidelines for SSIs. So your surgical procedures, if you keep those in infection control or if you keep those in your surgical site, it's always a great deal to go look at those and make sure you understand what's going on. As a part of the effort to reduce SSIs, again, conduct a periodic risk assessment for a time period defined by the hospital, select your measures using evidence-based guidelines, monitor compliance with best practice, and evaluate effectiveness. So as a preventionist, although this is something separate, a lot of times that we see, and you've got a surgical department director, make sure that we have indicators, whether that we have given these indicators to those folks to track, but you want to make sure that you've got indicators on these. Some of these are tracking surgical site infections. And also this can be, some of these are tracking the high level disinfection, sterilization process. Make sure that you've got those indicators with your surgical site and that they are reporting that data back to you. But especially you want to make sure that your SSIs that you're looking at, what type, what procedures, where they're coming from, what providers, what were the temperatures of the room. There's so many things that go into this that you want to get your indicators and make sure that they're followed. Okay, regulatory guidelines. So the first thing I want you to notice is look over to your right. Ton of stats, but just 313 million people get surgery. SSIs are 38% of those. It costs $10 billion. So, whenever we look at the landscape of healthcare and why they're cutting reimbursements and why whenever we have readmissions, they're not paying for those. Well, this is why. And it's things that a lot of the times they're at fault of a process, but we can do our work to prevent these. So moving back in, you want to measure your SSI rates for the first 30 or 90 days following surgical procedures based on your NHSN procedures or how you measure those. You want to provide process and outcome measure results to key stakeholders, administer antimicrobial agents for prophylaxis for particular procedures, and when hair removal is necessary, use scientific literature or something that's endorsed by professionals. So I'll go up to the first one. Why do we report this to key stakeholders? Because this is tied to money. A lot of the times when we have providers doing surgeries, we're not getting reimbursed for those. We need to have either some consequences or some advantages for the rates that we keep. And we'll talk about that in the leadership section, but that's going to be a big piece for your administrative folks. That's what's going on in their head. When we administer antimicrobial agents, there are some best practices. These have updated. Make sure that you're looking at what your current practice is. And if you've got an old surgeon versus a new surgeon, 1 gram, 2 grams, whatever you're giving, whatever medication, make sure that is, number one, approved and effective, and number two, evidence-based. You have to keep up with the times. Also hair removal. So, a lot of electronic razors, we don't want to compromise that area. But, the big thing I want to hear is any guidelines that you are using, you want to make sure that you validate the sources. So what's going to happen? It happens with processing. It happens with surgery. It happens with anything you do is if there is a question, the surveyor will go back and say, who do you follow? Do you follow CDC? Do you follow AORN? What are the guidelines? They're going to pull those and then they are going to say, okay, it says this. Are you doing this? So make sure that anything you do, it's backed up with scientific literature or from a professional organization. And if you are mentioning those folks in your policy, make sure that your policy lines up with what those guidelines are. Okay, SSI, as you see, look, you got this person that's been stitched up, but it's an infection that occurs after surgery on the part of the body where surgery took place, okay? So we have a shoulder surgery, and now we have an infection in that shoulder. It meets the criteria. Now we have a surgical site infection, okay? Can be superficial infections or deep tissue infections. And there is a whole line list of different areas of where this can happen. It is going to be, up to the surgeons once they either go back in to identify where this lies and then report that to you and for you to document. Healthcare providers must care for the site and change dressings on those. So sorry, I have a line in there, but it says we need to make sure that whenever we have a surgical site that we're looking at that area, if, while they're recovering, we're changing that dressing. And then also we're educating those patients as to how to change those dressings. And if they don't feel comfortable, invite them back to where we can give them a resource to help them change those dressings. Again, once they leave the hospital, now it's going to be up to them to make sure that they take care of themselves. So you want to be the best steward to give them education. SSI, redness, pain around the area, drainage, cloudy fluid from the surgical wound, or fever. These are all symptoms for you to look at whenever they come in. That may be indicative of a surgical site infection. And then prep and technique is key. I cannot stress that enough. It is all about, how they say measure twice, cut once whenever you're building something. This is the same thing. Make sure that your prep, your technique, your fields, make sure that all of those things in the beginning are on point and are followed through with your procedure to make sure that that infection doesn't happen. Take more time there. It's extremely important. Okay, some more evidence-based practices. You want to wash your hands and arms up to the elbow with antiseptic agent before procedure. These are great times for you as a preventionist to go in and watch some of these surgeons scrub. Some of them get in a rush, some of them don't do it properly. And if you notice that, you want to make sure that you do some education on that. Remove hair immediately before surgery with the electric razor in the procedure area. So this reduces the amount of error right here. So right before we're doing it, we take that electric razor, we shave that area, and then we can go forward with that. And the amount of time between that and when we have the surgery is very short, which reduces the amount or the risk for an infection. Hair covers, masks, gowns, gloves, all during surgery. Make sure that they are worn properly. Make sure that if you have folks with beards, that we pay attention to that. Make sure that if you have caps that are worn from home, make sure you have a process on how they're cleaned or how they're cleaning those. All of those different things. Remember, we are built for convenience. So anytime that we don't have guidelines or things to follow or hard stops on those items, we need to make sure that they're there. Some of the biggest things that we've seen in the past that ARN has brought up are items that are washed at home, cell phones, or items that we bring in from home, the types of scrubs that we wear, are they hospital provided or are they provided from outside? All those different things you can see in ARN as big issues. And I want you to recommend you stay up to date on those as well. And then antibiotics before surgery starts, usually 60 minutes and within 24 hours after surgery. Know your protocols and update those protocols. Of course, it is going to be up to that provider, but it does not hurt to give them what the best evidence-based practice is currently and what you feel is appropriate based off of what you're seeing if you're having SSIs. If we're only giving a half a gram of this and we're seeing a ton, and then another physician is giving 2 grams and they're seeing some very good success, Maybe it's something that we want to pay attention to, get those providers in the room, let them chat it out and figure out a solution. Others are pre-post operative orders, order sets developed, revised to match regulatory guidelines. Again, standardization. Whenever we have checklists, it's very easy to see if the steps were followed or if the steps were not followed. Also, it allows us to see if that step was missed. We can go back to that if we have a surgical site infection and identify, okay, now we understand there may be a break in this process. We want to decrease OR traffic with observations by IC staff or a designee. You know, if we're just hanging in there with a clipboard, you're probably going to have good compliance. But if you've got somebody, maybe a secret shopper that can look to see what that traffic looks like. Also, it may be inadvertent. It may be that this is just the easiest way to get around. And so they just go through this area. Well, we need to decrease that or find a solution where we block that or make that out of, you know, out of the accessibility of that staff member or whoever it may be, housekeeping, to where that traffic is not coming in and out. You got to realize air is moving in all of those areas, and air carries bacteria, viruses. So be good stewards of that. Chlorhexidine for pre-op baths, one-to-one education, and daily vigilance. These are just some good practices that we've seen with hospitals that are great. You know, those pre-op baths with chlorhexidine in it, those are not a bad thing. One-on-one education, asking, does that make sense? Do you understand? Okay, now walk me back through that. What are we having to do when we get home? Having that one-on-one time, because a lot of times this happens very fast. And in the moment, folks maybe not be comfortable to ask questions, especially to the provider. Providers are intimidating. But as a preventionist, we can be that one-to-one person that says, hey, look, I know there's a lot going on. Let's talk about everything. And if you've got questions, feel comfortable. I want you to be comfortable with everything going on. That goes a long way, let me tell you. And then daily vigilance, whether it's your nurses on the floor, whether it's your folks, your pharmacists coming in, adjusting, whether it's, you know, even you going in or your providers, make sure that we're looking in after these people have surgery, we're educating, reminding them, and then maybe calling in to check in and say, hey, you know, you had this surgery, how's it going? Are you making sure your dressings are changed? Do you have supplies? If not, come back and we can help you out with that. And then education. Like I said, many times when I'm reviewing cases of surgical site infections, it's not because of something that we necessarily did in the hospital. It's something that we forgot to teach them. It's taking showers the day after we have surgery or something, or it's jumping in a lake, or it's going work out and sweating in it. You know, these are things that we may have not touched on just because it wasn't standard practice, but you got to think outside the box of, okay, once this person leaves, what's the possibility that they're going to do different things? Millions of things, and make sure that they understand what could cause risk for them. Okay, with surgical site infections, you know, those are things when it comes to a financial, you know, liability. We'll talk about that in leadership, but you know, there's a lot going on in surgery. So as a preventionist, what I want to encourage you is not just to hand that off to the surgical site director, is to actively be involved, create indicators with them, possibly on an annual basis, go through their procedures or their protocols and make sure that you have a presence in there. You know, it's one of the biggest things, not, you know, when it comes to disinfection, sterilization, high level disinfection, all those things, those are very detailed. Surgery is extremely detailed, and your surveyors will be coming in watching a surgery if you are having those on those days. So you need to make sure you are in tip top and you're ready to answer questions if you have spikes in SSIs about what you are doing. So, all right, closing the chapter on that one. Now we're going to catheter-associated urinary tract infections. And with CAUTIs, these are, I mean, everybody has seen, especially if you're a nurse, you've had to work with a catheter, you had to insert a catheter. I mean, it is just part of what we do on a day-to-day basis. So, you know, it's not funny that this is the, you know, the highest percentage of hospital-acquired infections in the nation because it's used so much. So let's go through the guidelines. From Joint Commission, we want to implement evidence-based practice to prevent indwelling catheter-associated urinary tract infections. Again, you see it on every reg. Educate. Make sure your staff and your practitioners are involved in indwelling catheters. We teach them about CAUTIs and the importance of preventing those. And also education upon hire, granting privileges when involvement, and for your patients. Let them understand what's going on. Let them understand positioning. Let them understand why we do what we do. So that's extremely important. Also, since this is such a high percentage, we want to make sure that there's ongoing education and some competencies that go with this. Step by step, our staff that are involved with this understand what insertion, care, removal, and manipulation looks like. So that education is key. Okay, patients, we need to make sure that not only the patient, but their family, we get families in the rooms and they start messing with things. Well, we need to make sure that if that family is in there, that they understand the risks with that. Since it is that system is introduced into the body, that they don't need to be tampering with that, and its use or why it is. Some folks that come into the hospital that don't even know what that is bizarre to them. Help them understand why it's needed and help them understand what we need to do with that. Okay, develop criteria to use when evidence-based guidelines are there for the placement of indwelling catheters. Look, I see this time and time again. It does not need to be a standing order to have a urinary catheter. That is the worst thing you could possibly do, is just put it as a standing order. You need to have criteria, and you need to go through that criteria, and you need to have your nurse questioning that criteria if a provider just wants to write for an indwelling catheter. This is not a convenience tool. This is absolutely not a convenience tool. This is a tool when it is needed, and that criteria needs to be there for that your practitioners and your nurses understand that it needs to be there. Okay. Follow written procedures based on the evidence-based guidelines for inserting and maintaining. CDC has a pile of resources. I didn't put it in here, but a great resource, go to the CDC under CAUTI, and they have a literal list about a mile long about every step in the process. What I recommend, take that, put that into your process. It is literally everything that you're going to need when it comes to preventing catheter-associated urinary tract infections, from prep to storage to manipulation to change to all those different things. A blockage, it talks about it all. So I encourage you to go to that resource. And then measure and monitor catheter-associated urinary tract infection prevention processes and outcomes in high volume areas by doing the following things. Okay. You want to make sure that, all of these before touching the patient. You want to look at before clean aseptic technique happens. You want to look after touching the patient. You want to wash your hands. You want to look after body fluid exposure risk. You want to wash your, all of those different things. You can see how many different things are included whenever we're dealing with a urinary catheter. And all of those things, most important thing, hand hygiene, but all those certain things we need to make sure that we understand and we're not introducing anything there. So huge piece. Okay, now when we talk about a CAUTI, what is it? It is an infection involving, and a lot of times people don't understand this, but it's any part of the urinary system, the bladder, the ureters, the kidneys. Anytime we have an infection that is caused by this catheter in any of those areas. It is the most common type of HAI in the nation, without a doubt. 75% of UTIs are caused by catheters. That's insane. And that's why we say there needs to be criteria, and we don't need to just have this as a standing order to put on anybody. It is extremely important to make sure that the criteria is met, and it is absolutely needed for that patient. 15 to 25% of patients receive urinary catheters during their stay at the hospital. So, you're looking at a good quarter of your population. And again, I'll put that only used when needed. It is so important that we only use these when we need it. So with CAUTIs, evidence-based practices, we're looking at a couple different things: catheter placement, catheter care, catheter removal, and catheter reinsertion. So the top items that I wanted to mention and cover were appropriate use. So as we're going through that criteria, are we looking at a patient who has problems mobilizing? Are we looking at a patient who has comorbidities that require this? Are we looking at a patient that's going to be on a vent? Are we looking at a patient that is incapacitated, that is not able to mobilize? We need to have that appropriate use. Also, we want to make sure that when we say appropriate use, is this the actual, do they need an indwelling catheter, or is there another solution? Is that a condom catheter we can use? Is there different items that go into the field that have this? Technology has changed. Do we absolutely need that indwelling catheter? And once we establish that, we establish our baseline, we use it appropriately. Okay, proper insertion. So this is something that from nursing school that they've taught all the way into our practice, and it is a step-by-step guideline. The best thing I can say for your proper insertion is have a flow sheet, and make sure that when you're doing your competencies, your nurses are checked off on every single thing, and that whoever is deeming them watches the process. Maybe it's something as an infection preventionist, you want to go and get consent to watch the process. I mean, those things, if you're having those issues, you want to make sure that you, as the professional, are looking at every single thing to make sure whenever they're inserting, we're disinfecting properly, we have our field, we make sure that we are checking the patency, we're making sure that we're securing that right, we're in the right area. All of those things are so important. We're looking at making sure that urine isn't backing up. We're making sure that it's below the bed or below the body. And anytime we're moving, we're not just chunking it up. I mean, all of those things matter, and that goes into proper maintenance. When we have that catheter, are we emptying that properly? Are we opening that, letting pathogens get in, or are we maintaining its security, checking those different things? And if we start to notice those things, are we taking action on those? Another thing that comes up is management of obstructions. I've seen folks just try to flush out that is absolutely not the right way to do things. Make sure when you are dealing with something like that you take all precautions to make sure that you are not introducing or you are damaging any of that patient's, tissues or body features. You want to make sure that you are doing it properly, you are following the procedure, and that obstruction is cleared, not forced clear, okay? And then remove it as soon as possible. I cannot emphasize this more. To prevent CAUTIs, make sure that, if they need it, it's needed. We take care of it, but it is removed as soon as possible. Do not let this become a convenience issue. And I think across the nation, we see it. It is just used as a convenience mechanism to where it's something that we don't have to go and get that patient up and down out of the bed. But again, realize compassion goes a long way in this. These patients are struggling, and we need to provide the care that we need to them and not just leave this instrument of care in there whenever it doesn't need to be there. So a lot to be said about CAUTIs, and I didn't want to put all that in here. I do want to give you some references, and I can share those with Danae, but the CDC does an unbelievable job where we've literally taken those plug and play into our checklist, and we've had facilities that have very high success rates and very low CAUTI rates. Always remember, simple, consistent processes decrease the chance of infection. If you can make the process very simple, and you can have staff that are educated and in an understanding of this is what we need to do, you are going to absolutely decrease the chance of infection. From CLABSI to surgical site to CAUTIs, the biggest thing, and we all saw this most recently in COVID. Maybe we saw a little bit more because we worked with a lot of folks, but whenever your staff feel comfortable, they feel confident, they feel educated, and they understand what they're doing, then fear goes out the window. And I feel like, especially when we're talking about hospital-acquired infections, it is so important for your staff to be educated, knowledgeable, and confident, but also for your patients. Whenever this happens, make sure that they understand, make sure they have resources, they can read up on it, they have questions, we're answering those so that they're confident while they have that going on, or whenever they go home, they understand what they need to do to care for themselves to prevent that infection. Okay, HAI prevention strategies for success. We're going to go into the elements that we feel are extremely important that a lot of preventionists don't look at. And the first one is leadership, okay? Having your leadership commit to this program is crucial for the success. If they don't understand what the risk is for hospital-acquired infections and they don't quite understand how this affects, the patient, or their reimbursement or anything, safety in the hospital, they need to be on the same page, and you need to be an advocate to make sure that that's there. Another one is have resources dedicated to decrease hospital-acquired infection rates. Make sure that they have the supplies, make sure if there's a better catheter, a better intervention, put that in the budget to try to get that, if that's something that helps. They need to support HAI reduction by top level leadership. The leadership needs to understand why we do the things we do. Have financial incentives for practitioners to reduce HAIs. It is the easiest way to talk to a CEO about, hey man, we've got all these surgical site infections that are coming back. That's readmissions. We're not getting paid for those. We need to take this serious and do something about it. You'll get his ears perked up when you start talking about financial deals, but also on his end, having those financial incentives from leadership to make sure that our practitioners, they are being extremely more cautious, and that's tied to incentives. That's just one way to make sure that they're following their deal, following the guidelines. One of the things we see is practitioners just, some of them get burnt out and they just go through the motions and they're going for volume. Well, that doesn't help anybody. We need to make sure that they are bought in and they have a reason to take their time, follow these processes, and do a good job. And then provide time specifically to focus attention on HAIs that happen in the facility and update adjust processes. Sit down in your infection control committee, sit down with your surgical committee, sit down with the governing body and talk to them about these things. You know, whenever we say that this was caused by the hospital, that's not a good look. You know, publicly, it's not a good look from the standard of care that you provide. You want to make sure that those are being brought up. And just like anything in quality, we're working to fix those, identify, put a plan in place, take action, and fix those items. Next thing would be practitioner accountability. So your practitioners, they need to accept accountability and responsibility for what they're doing and in preventing HAIs. So whenever they buck the process about, well, I don't want to do this, it takes too much time, make sure that you talk to them about why we are doing this. And I will encourage you to find somebody that is highly engaged, like a champion, to help you decrease HAIs. You know, coming from a nurse to a doctor, or to a nurse, not necessarily a nurse practitioner, but to a physician, they take more information from their peers. So if you have a physician that is bought into this, communicate with him to let him or her communicate with the other practitioners to try to get buy-in. And now you've got communication on their level that they'll listen to. We know practitioners can be a little tough. Physicians can be a little tough sometimes. I'm sure I'm not the only one that's had issues. So, all right, antibiotic use needs to be seriously reviewed and implemented per protocol agreed upon. Again, you know, we do this with antibiotic stewardship, and nothing is different right here. You know, with surgical site infections, we're looking at pre-op, post-op. Is that the right dose duration indication? Or, I mean, excuse me, is that the right dose duration and the right antibiotic? Or do we need to change that up? And then case by case review helps prevent further HAI. So when you have a surgical site infection, when you have a CAUTI, a CLABSI, we take those cases and we look through the whole state. We look through the whole chart and we try to identify what broke in the process that caused that and how we can prevent that moving forward. Okay, process improvement, okay? These are just some other items that you can touch on to help prevent your HAIs. Acting on HAI issues that come up, ensuring they're tracked, cases reviewed, patients treated. We just talked about that. Use specific patient education for specific type of interventions and types of HAIs. The biggest thing that we recommend is have some informational sheets that we can go through as you're walking through. Make sure that you're highlighting that, or that they're highlighting or circling different things, some important things. And it doesn't hurt to say, hey, this is important. This is important. Make sure you pay attention. This is something you need to know. When folks are triggered like that, then they know, okay, I need to pay attention to that. So that's a big piece about patient education. The more they know, the better they can do once they're outside your facility. Involvement in QAPI to track and trends. So this is going,
to do that, you'll need to turn off.
Hang on one second. Siri's listening. Anyway, so quality. You don't only need to track how many of those things that you have in your facility, but you also need to trend those, because when you trend, now you can see, are you having a spike? Did you have a new practitioner come in at that time? Did you add a new procedure? Did you add a new piece of equipment? Once you go back to research, and when you're trending, you can see the full picture, where if you're just tracking, you're just seeing that time and space right there. So make sure to be involved with quality. Use a multidisciplinary team, all the way from lab to pharmacy to your practitioners to infection control, to any department that's going to be involved with this. You want to make sure that you have multidisciplinary buy-in so that you understand what they're seeing. They may be giving you feedback for something you didn't know, but again, we can't be involved in everything, so we have to have that buy-in so that we can get that information to move forward. Benchmark or use comparisons. So see how you're doing against local hospitals that are by you, hospitals of the same size that do the same thing. Always benchmark, you know, see where they at, or see where the national average is, and then say, okay, we really need to do some work, or say, okay, we're good, but we still need to work to get better. Use IT infrastructure and resources, you know, triggers, things that as we're charting, if we're using a paper chart or EHR, does it have hard stops where you have to do these certain things before you can do that? So all your IT resources, you know, what those are good at is they're good at asking the questions and making sure that those things are done before you can move forward to the next step. IT is a huge thing, especially with tracking as well. Make sure that you're using your IT resources appropriately. Financial incentives and disincentives, we talked about that, but that gets the needle moving for some facilities with practitioners that are motivated by that. You know, those things are something you'd have to bring up with leadership and they'd have to agree on, but it may be something that they're interested in if they are getting a lot of payments, you know, recouped, so are not getting paid for patients. Evidence-based practices, I'm going to encourage you, if you're a rural hospital, to constantly stay vigilant with updated practices. And then don't be afraid to reach out to your larger acute care hospital partners. You know, a lot of hospital systems have big resources. And like the last thing says is participation in a group. You know, it doesn't have to be a group. You can just reach out to your local preventionist. You know, we have a network, APIC, the regions that we function in. I encourage you to join APIC, be a member of that. A lot of the issues that we see are pushed through there, and this is in the same state. So that's a great resource. And then constant vigilance, like I said, to stay updated. Those are the biggest things that I can say are important. And at the end of the day, don't do all that stuff and don't give yourself, make sure to give yourself credit. Give yourself credit for everything that you do, all your process documentation, all if you've improved from this rate to that rate, make sure that you document that, okay? Whether it be in a special project, whether it be just stuff that you report on a monthly, quarterly basis, give yourself credit for the hard work, because when the surveyors are coming, they're gonna ask you, what are you proud of? And make sure you show them the hard work and that you're proud of that. Okay, some reminders. Again, if you've not filled out that application, make sure you go on there. We've got links on the LRHA website to take care of that. The link is open. I think we have a few more spots. I know Danae's going to get a new count, but make sure you do that. And then again, if there are any questions at all, please don't hesitate to reach out. I know we covered a ton when it comes to everything with infection prevention and control. This past year has been a roller coaster where COVID has kind of taken the front seat, but now that we're getting back to somewhat normal, we have to remember to take care of the rest of these things. So with that, Danae, I will turn it back over to you.
All right, thanks so much, Taylor. I'm going to launch a quick closing poll for you guys if you'll take that for me. And while you're doing that, if anybody has any questions, feel free to pop those in the chat. You can, do the little raise hand reaction icon if you want to be unmuted and ask your question out loud. We're happy to do that. So we'll just give it a minute for y'all to take that poll and see if there's any questions. All right, not hearing any questions. We will go ahead and wrap up. So thank you so much, Taylor, and thanks to everyone for joining us. I will put the post survey link here in the chat. That will also go out via email again. Again, we do ask that you complete this survey. It's required for our grant evaluation and helps us improve for future events. The recording should be available on our website within the next couple of days. Again, you'll find that on our website. I'll send that out via email as soon as it's available. As always, please feel free to reach out to us at LRHA if we can be of any assistance at all. And thank you so much and have a wonderful afternoon.